So thank you very much for hosting me here today, and it's been a real pleasure working on social determinants of health with an increased focus on sort of practical interventions in the state of Rhode Island. So they asked me to talk about social determinants of health, which is a very large topic. So I thought I would give an overview, but then start to drive into a few key examples that I feel are quite innovative and actionable these days, along with some examples of some local interventions that are addressing social determinants of health itself. For those of you taking CME credits, this is the educational objectives of this talk, so I'll try to definitely address all of those. We'll check in with them at the end of the talk too. So I'm trained as a cardiovascular physiologist and a social epidemiologist, so I spend a lot of time looking at the biological mechanisms by which social factors may influence heart disease risk. And if you look at sort of introductory physiology textbooks, they often talk about the basic organization levels of the body. And I know this isn't a talk on physiology, but if you will hold with me for a minute, it gets kind of interesting. And so, you know, the very basic level of organization of the body is the chemical level or the molecular level. So our cells are made out of molecules that are all interacting with each other to allow our body to do what it does. And as we move up in sort of level of organization, we get to the cells that are these collections of molecules, and the cells themselves are sort of these collections that are working together to make the cells do what they do. We then get to tissues that are collections of various different cells, organs that are collections of various different tissue types, organ systems, and then the organism level itself, and that's basically the human body. And this textbook actually describes the human body as it can be viewed as a complex society of different cells working together to carry out the functions essential to the survival of the entire organism. And I like how they talk about it being a complex society of different cells working together. And so if we take this sort of society of cells working together and we kind of shrink it down, those 6 different levels, into this box here, we start to see that the body is embedded in communities with various different attributes. Social attributes, biological, the built environment, health services, economics, population-based health programs, collective lifestyles and health practices. All that is embedded in a certain context of the natural environment, culture, politics, and a particular place and time in history. And so a lot of the work that I do looks at how these factors outside of the body, and many of these are social determinants of health or environmental determinants of health, how they actually influence the physiology of the body and the physiological underpinnings of diseases. And so this talk is sort of providing that overarching context and how the sort of environment outside of us, particularly the social environment, may influence the biological underpinnings of disease. And so this is point number 1 on the education objective, so make sure you've written this down if you're getting the CME credits. Just kidding. But this is sort of the definition of social determinants of health, so they refer to both specific features of and pathways by which societal conditions affect health, and that can potentially be altered by informed action. So these are some examples here, like income or education, occupation, social integration, discrimination, working conditions, that sort of thing. And so I'm going to highlight, we started broad, and now I'm going to move into 3 specific social determinants of health to kind of dig into a little bit. And again, we don't have a whole lot of time. I teach an entire course at Brown on social determinants of health, so this is just a sort of a flavoring of some of the kind of cool stuff going on right now in the field, I would say. So we'll be looking at implicit racial bias, education, and the family psychosocial environment. So starting off with the implicit racial bias. So one of those things is, well, what is implicit racial bias? And so that's what we've referred to as unconscious discriminatory attitudes towards certain race groups. And then there's sort of explicit bias where it's consciously discriminating. And so in the US these days, if you ask the vast majority of people if they have discriminatory attitudes towards say African Americans, the vast majority of people say no. But the vast majority of people have implicit biases that are sort of on the subconscious level that they may, if they get, and this is some research that's been done, where if they've sent resumes to businesses that are identical to each other, the only way that they differ is by name, where one name has obvious European ancestry and the other one has obvious African ancestry, and there is a higher likelihood that the person with the European name will get the job. And so that is an example, that may be an example of implicit racial bias, where someone would be looking at the resume, they don't necessarily think that they have bias towards certain groups, but they see a name that is more familiar to them, and it may just sort of be a little nudge that, well, this person seems like they'd be pretty good. I'd probably interact with them better. There's can be those little nudges throughout life that can create subtle shifts that can have preferential biases towards certain racial ethnic groups. And so this can be tough to think about, but we're starting to be able to measure it. And once we can measure things, it can really make a difference. And so I would actually encourage you to, you can measure it on yourself at this website. And it's called the Implicit Association Test. And basically the way it works is faces come up that are either of European ancestry or African ancestry. And then you basically have one button that you push if it's on the left, and a different button that you push if it's on the right, and it times you. So when that picture comes up, if the person's European American, then we would click on the left button. If a word that came up that was bad, like say violent or aggressive or that sort of thing, we would also click on the left. If the face that came up was African American, we'd click on the right, or if a good word like honest or kind, we'd click on the right. And so basically, if we have better lubricated neural networks that associate good characteristics with a certain racial ethnic group, our response time will be faster. And so this is an example. If someone has a pro-white bias, they will be slower at connecting these because they don't necessarily, they're less likely to associate bad words with European Americans. And so this kind of gets past the conscious biases and gets to the subconscious biases. And so it's a nice way to be able to start to measure this characteristic. And so of the tens of thousands of people that have responded on this Harvard site, 70% of people have a preference for white people compared to black people. And that's worldwide, but the majority of respondents are in the US. 12% have a preference for black people compared to white. So this is a huge challenge in society right now. This is what is often being referred to as modern racism, where we're less likely to say that we have racial biases, but we have these subtle ones that kind of just come up. And now that we can measure it, we can start to be able to be more aware of it within ourselves and within our culture. And so there's been some quite nice studies on it. This was published in the journal Science in 2009, so one of the top journals worldwide. And they basically did a study where they took very popular television shows that had African American characters in it as well as white characters in it, and they took out all the audio. And so then they had people rate people's interactions with white people versus black people, but they blocked out the person that the actor was interacting with. And they found with these ratings that when an African American actor was being interacted with, the body language was less friendly than if the actor was interacting with a white participant. And when they compared the audio, there was no difference in the audio, in the words that were coming out. It was purely in the body language. And they showed that participants who watched more of these types of television programs had a stronger pro-white bias on the implicit association test. But maybe it's just because people with a pro-white bias are more likely to enjoy these kinds of television shows. And so then they did a second experiment where they created actors that had a pro-white bias or a pro-black bias and had people watch these shows and measured their sort of positive reactions before and after. And these are the changes here. And they found that when people watched pro-white actors interacting with each other, their pro-white bias increased. And when they watched pro-black interactions, their pro-black bias increased. So this showed that it's also modifiable. And it also showed the impact of these subtle conditions and exposures in our lives, like the kind of shows that we watch. How many subtle exposures are there in our lives that are kind of creating us to have this implicit bias, whether it's for pro-whites or straight people versus gay people, Arab Americans versus white Americans, American Indians versus white, like whatever it is, there's implicit bias tests for all of those things. And so this is to me, a very interesting area that really deserves further study. This is a study that came out in the New England Journal of Medicine in 1999, so it's sort of a classic. But they basically had physicians at a conference watch videos of actors that were presenting with identical cardiovascular risk factors that would put them at risk for coronary artery disease. The only difference was either in their gender or in their race. But otherwise, they presented the exact same script and the exact same risk factors. And then they asked physicians to estimate the probability that these people have coronary artery disease. And they said, they reported no statistical differences in probability of having coronary artery disease between white and black participants. The optimal treatment for these participants, given the risk factors, was cardiac catheterization. But black participants were 40% less likely to be recommended for cardiac catheterization compared to white participants. And so that's an example, identical risk factors, the only difference was race. And this has been shown with thrombolytic therapy, for example, in other studies too. And so I think sort of in conclusion, the findings suggest that implicit racial bias is that it's modifiable, and so that's good news. And the second piece is that it may negatively affect the health of racial ethnic groups that experience negative racial bias. Nancy Krieger, a professor up at Harvard, came up with a paper once that the title was, Did child abuse happen before 1968? And then she went on to sort of talk about race. And of course it did. But around that time, a major report came out that shifted the culture around being able to talk about it and be able to address it. And I would say it's something similar these days, where does implicit racial bias exist? Of course it does. And now we're able to measure it. And by being able to measure it, including within ourselves, it can help us understand the biases that come up within us, and then to take more skillful action knowing we have those biases, if indeed we do. And so this is sort of one of the first areas of social determinants of health that to me is quite innovative and holds a lot of promise. And so that's sort of the first one. And then the second one is around education. So we'll just take like a breath for a moment to clear our brain as we move on to the next topic. So with education, it's sort of broadly under the category of socioeconomic status or socioeconomic position. Those two words are used kind of synonymously. And this is a definition of socioeconomic position, but basically the social and economic factors that influence which positions individuals or groups will hold within the structure of a society. The three most common ways to measure it are through education, income, and occupation, but there are many other ways, whether it's wealth or area level, socioeconomic circumstances. I focus a lot on education because one is it's modifiable. Two is kids can't help who their parents are, and it's something that gets completed fairly early on in life, and that there seems to be a reasonable amount of public support for education. America has a big history of putting a lot of emphasis on education. And perhaps that emphasis could continue. And so for me, I feel like it's a modifiable social determinant of health, and that may be acting at sort of a sensitive period in the life course in early childhood when people are still developing. And it has the potential to lift people out of poverty so that these income and occupation that are often driven by educational attainment may be less of an issue. There's been a lot of research on education and its effects on health. This is a systematic review and a meta-analysis. Each one of these dots is a different major study that looked at the relationship between education and ischemic heart disease. This little tiny diamond down here is the effect estimate for all of these studies, and it basically showed a 34% higher risk for lowest versus highest educational group for ischemic heart disease. And this is observational studies, so these aren't interventions, but observational studies. So as education goes up, heart disease risk tends to go down, and that's been shown over and over again. And so how could that happen? So does education really, does it influence knowledge, maybe health literacy, people's abilities to read their medication prescriptions, for example? Does it improve things like self-efficacy or learned effectiveness, access to medical care? Education influences income and occupation, so that can then improve, the neighborhoods that people live in and the types of foods that they can buy that could then all influence these, physiological and behavioral underpinnings of heart disease. So are those likely the pathways? And I've done some work, parsing some of this out, and those are some of the potential pathways. But another thing is, maybe it's not education, maybe it's just intelligence. Smarter people are more likely to get higher levels of education, and they're probably more likely to be better able to take care of their health. And so is that what it is? Is it parents' mental illness influencing their kids' education? Our parents' education occupation is a huge driver of our own education. So is it really our parents' education driving it? Is it time preference, the ability to plan ahead? Kids who plan ahead are more likely to plan ahead to get greater levels of education because it can improve their life long term, but they're also more likely to plan ahead and not smoke because it might influence their health, not now, but a long time from now. So maybe it's really those things that are driving it. And most of those studies that I showed you didn't account for these things because they're so hard to measure. And so one of the studies that we did is we actually have this information in a birth cohort of people called the New England Family Study, where we took direct assessments prenatally through age 7, and then we've been bringing them back up through age 50 now to look at risk factors for heart disease later in life. And so we have all these factors, including intelligence measured at age 7, the childhood chronic conditions, medical conditions, parent psychiatric history, parent socioeconomic circumstances, various different demographic factors. And we put all of those into a propensity score matching approach, which is a fancy statistical method to basically account for a whole bunch of these potential confounders. And we found that when we didn't include those with people with a college degree had a 28% lower likelihood of having heart disease in the next 10 years compared to those with high school or less. And when we accounted for all those early life factors, the effect went down by half. So those early life factors do appear to be important. They aren't accounting for everything, but it kind of makes sense that our parents' education influences ours, and intelligence will influence the amount of education that people get. So this is a stronger causal test about if it truly is causal. And then another question is, well, what do we do about it? Do we just tell everybody to get a college degree? Do we make education, should we make everybody go to 13th grade instead of 12th grade? Do we improve the quality of education? Do we reduce class sizes? Do we improve the quality of the teachers? What do we do about this? What are plausible, actionable interventions that can take place? And so this is an example of some studies that have looked at some of this. So this is, it wasn't always in the US that we had to go through to 12th grade. It used to be 11th, and before that it was 10th, and before that it was 9th. So there's been these policy shifts that have influenced mandatory schooling laws. And so economists do these like regression discontinuity designs where you look at people before and after the policy went through, and the policy often gets implemented at different times in different states. So you can look at neighboring states where they're very similar, in characteristics, and then see the impact of that policy shift. So Laris Mooney published a paper in 2005 showing that in the US, for each additional year of compulsory schooling, it decreased mortality by about 3%, which is a fairly big effect. That study was aimed to be replicated in France, and they weren't able to replicate those findings, so it's a bit controversial right now about if additional schooling makes a difference. But we need some more studies on that to give us that information. Another place we can intervene is early on in life. And so this is, many of you have probably heard about the high scope peri preschool program. This was basically like enriched preschool. It's basically the start of early Head Start, for which Rhode Island's been getting a fair bit of funding to expand. And so basically they're providing a very nurturing environment for kids, low child staff ratio, high level of outreach to parents, developmentally appropriate practices, staff well trained in early child education. And so they've done over 40 years of follow-up now. And at age 27, the program was associated with higher earnings for the participants, increased high school completion, lower likelihood of receiving social services, fewer criminal arrests. And by age 40, this came out in 2009, they basically looked at the kind of things that you can measure in people at age 40. I think it's self-report. So preventive medical care, traffic safety, drug use, And this is sort of the overall health behavior mean. And so those in the treatment group tended to have healthier health behaviors than those in the control group that was statistically significant. So this is sort of evidence that early life, high quality schooling may influence health for the rest of the life course. And this is a fairly small sample size study, but there have been other studies such as the Advocacy project, for example, that have shown other early life interventions showing enriched environments early on in life may influence health across the life course. And so, conclusions on the education piece is that the findings suggest that education is likely important for health, both actually mental health as well as physical health. However, the specific types of education interventions that would have the highest health impact remain unclear. So what are we going to, where we see these associations, but the point of the spear for the research right now that I would say is around interventions. And I would actually generalize that to social determinants of health as a whole. As we see all these observations that social factors are related to health outcomes, but what can we do about it? What are plausible on-the-ground interventions that I believe many of you are already engaged in that will actually have an effect? And there's some promise, for these early life interventions. I also think real interdisciplinary collaboration between experts in education and experts in health would allow for a greater amount of high-quality research to actually see the impacts of education on health outcomes. So I'm just checking in with the time. Okay. So now we're on to the third one, the childhood, family, psychosocial environment. So again, I'm just sort of doing a menu of 3 kind of cool social determinants of health and sort of where the field's at. And so that's the definition of the childhood, family, psychosocial environment. So this is basically, you can read it, but looking at this family environment characterized by the presence of absence of cold, unaffectionate interactions, conflict, aggression, neglect, these sorts of things. And so, again, I'm a cardiovascular guy, so I tend to show research on heart disease. But how might the childhood family environment influence heart diseases, particularly the psychosocial environment? So for example, in adults, the vast majority of adults who smoke started in adolescence, before the age of 18. And that's when most of them are in with their families. And kids that have high-risk families with high psychosocial adversity, exposed to abuse or neglect, or their parents just aren't really monitoring what they're up to, they're more likely to smoke. And smoking is highly addictive, and it's a big risk factor for heart disease. And so once people start, it's really hard to stop. So the adolescence may be a sensitive period for some of these factors that may get started that really continue throughout the life course. So that's just an example with smoking. Obesity is also higher in kids that have an adverse psychosocial environment in the family, and including people that are exposed to abuse and neglect, including physical abuse and sexual abuse. And we're still sorting out exactly what those pathways are, but it's there. It shows, there's systematic reviews on this and meta-analyses. It also seems to influence things like depression and anger and hostility, and these are risk markers for heart disease. Also, kids with adverse psychosocial families have a harder time getting higher levels of education and good jobs and stuff too. So those are maybe some of the pathways. But this adverse childhood experiences study, huge sample size. It was in the Kaiser Permanente database, which is a health management organization. And this came out in Circulation in 2004, which is the top cardiovascular journal worldwide. And it influenced me a lot, but it influenced the field too. And so they asked people about their childhood exposure to things like emotional abuse, physical abuse, sexual abuse, and found that, for those that had childhood emotional abuse in their family, they had a 70% higher odds of having ischemic heart disease. 50% more likely to have ischemic heart disease if they experienced physical abuse. 40% more likely to have ischemic heart disease if they had sexual abuse. If there's domestic violence, higher risk. No association with parental marital discord. If their parents had mental illness, they were at higher likelihood for having ischemic heart disease. If there was substance abuse in the family, it was higher. Crime in the family, it was higher. Emotional neglect, it was higher, and physical neglect. So on all these measures, it was predicting ischemic heart disease. And this was very novel. And it's, for those of you who listen to NPR, there was a whole series on this about a month ago. with Felidi, who was on this paper. And then if you add up all those 8 experiences, those who had 7 or 8 of them, 360% higher risk for ischemic heart disease. This is adjusted for factors on the causal path. We think it would happen through smoking and through physical activity and BMI, so that gets lower, which we'd expect. And so, these were big findings. We looked at it in the Heredia study. That's a study of about 3,500 African Americans and white participants in the US in 4 different cities, and found, we separated out by a different kind of question. It's called the Risky Family Questionnaire, and it gets at it gets at some extreme things, but also just some things like, did your family know what you were up to? And that, for those who were in the riskiest scores, so a score of 1 to 3 versus 0, for males, they had a 7% higher likelihood of having heart disease in the next 10 years, and for females it was around 6%, and that was statistically significant. How often did you feel loved? Wasn't statistically significant. Physical abuse in females, but not males, was important. Getting physical affection, less so. Living with a physical or drug abuser, less so. In females, if they had some verbal aggression towards them, it predicted. And even just, was your house well organized or managed? That predicted in both genders. And so that's sort of getting at some of these pieces around, starting smoking, for example, in adolescence. So, these were some of the findings that we looked into. And so then, again, as well, what can we do about that early childhood environment? Is there anything that can be done? And are preventive interventions possible? And so some of you may be even involved with this particular program. This is the Nurse-Family Partnership. And this was a study that came out in JAMA in the late 90s. So it's sort of a classic in the field that's influenced policy and programs. But they basically had, in higher risk families that I believe were living below the poverty line, nurses visited an average of 9 times during pregnancy and 23 times from birth to the child's second birthday. And for those of you who are parents, myself included, I didn't get a whole lot of training on how to be a parent, and then I had twins, so there was 2 of them, and I didn't know what I was doing. And so to provide parents with this kind of skill set early on in life may help at a critical period. But it also helps the women around, say, participation in the workforce or educational achievement, family planning, linking them to their families, their family members and friends to support during the pregnancy and birth and care of the child. So it's a fairly holistic intervention that gets in early and sets people up for success. And so if we look at this study, follow-up to age 15 of the offspring, the incidence of arrests were significantly lower in the group that were randomized to the nurse visitation, and it was a lot lower for the incidence of convictions and probation violations. If we look at sort of sexual activity and cigarette and drug and alcohol use, there tended to be protective effects, particularly in the low SES, sort of in the single moms that were of low socioeconomic status. In this particular group, there tended to be lower sexual activity at age 15 and also lower alcohol consumption. So there were some early indications there, potential effects of this intervention. And so that's one that may help with the sort of family, childhood, psychosocial environment, is sort of coming in and helping the families start kids off. Another piece is, for a lot of kids that are in homes that have adversity, these enriched early childhood preschools may also help if we can bring the kids to an environment such as this peri-preschool program that I've already talked about. So those are some examples of potential interventions, and I've already showed these slides. So in conclusion on this piece, this early family psychosocial environment may increase risk for both mental and physical health conditions, and interventions are available that can reduce the health risks. So that summarizes sort of these 3 different social determinants of health. And so now we're going to move into some examples of local interventions. And so, many of you may be part of some of the ones that I bring up. So Health Leads is an example of an intervention that basically allows physicians to write prescriptions for things like basic resources for participants to be healthy, whether it's food or heat or those types of things. And then the patients can then bring those prescriptions down to the Health Leads desk, where college student advocates can work with those patients to access community resources and public benefits. So things like SNAP or WIC or various other programs that can help people that can be difficult to access and also difficult to know about if people are in the throes of working 2 jobs and living in poverty. They just have all these other issues that they're struggling with. To know about all these resources can be really limited, even if those resources are free and available to them. And so this program helps connect patients to those resources. Another example are some CDC-funded programs that have gone to the Department of Health at Rhode Island. And the Department of Health has been increasingly focusing on upstream social determinants of health. Even if you see the way the budgets are allocated, they're increasingly getting allocated towards higher upstream determinants of health. And there's some, in my opinion, some real heroes at the health department that are really leading a lot of this work, including writing grants to get funds to allow these programs to happen. And so 2 of those grants have been from the CDC. One is Wise Woman, that provides low-income, underinsured or uninsured women with chronic disease risk factor screening. So for women that don't either have high deductibles or they just don't have health insurance, they can get free screening for heart disease risk factors, and then they can get free interventions like Weight Watchers or yoga programs or memberships to the YMCA or diabetes prevention program. Various different evidence-based interventions can be made freely available to them. And Wise Woman is actually part of the women's cancer screening program that's been happening in Rhode Island since 1995. And that provides a similar set of women to have free cancer screening and treatment. And that program alone has diagnosed 397 cases of breast cancer and 32 invasive cervical cancers just since it started, and provided treatment for over 2,000 women. So that's an example of addressing at-risk women who wouldn't necessarily be getting these resources without the help of people in Rhode Island. The Green and Healthy Homes Initiative is an initiative that's been happening for several years now. It's spreading quickly across the US, and my wife happens to work for them, so I got a nicer graphics for this slide. But they're basically, they look at homes and make interventions both to make them more efficient from an environmental perspective as well as more healthy. So say if someone wants to seal their home, it's a really cheap way to save on energy costs, to caulk all the windows and everything. But if they have allergens in the home or asthma triggers like cockroaches or dust or even lead, for example, we may be sealing those in and actually making the home less healthy. And so this organization comes in, addresses both the health aspects of the home like lead and allergens and asthma triggers, as well as the environmental aspects that can really save a lot in terms of heating costs, and then brings in contractors that do the whole thing at once. And it's very efficient when you get people coming in all at once because it's the same people there doing the same thing. And then they also get funding from various different grant programs that are already existing that they just know about and can funnel in. There's philanthropic aspects to it, but then there's also private sector because these people are saving money now. And so if a loan is given to pay for some of those upfront costs, people can start to pay back that loan with a little bit of interest over time from the savings that they have in their home. So it's quite a cost-effective, innovative program that's really, you'll probably be hearing more and more about it. And then there's things like the family visiting program that takes place out of the Department of Health and is very much based on the nurse-family partnership. I think they're basically, they will visit any Rhode Island pregnant woman and parent with a child up to 3 and provide those kinds of resources that we talked about. There's examples like the Met So the Met is this very innovative public school in downtown Providence. There's also a site at Newport that takes kids, it puts them in small classrooms, no more than 16 or 17 people in a classroom, and identifies their interests and then builds a curriculum around their interests and allows them to grow and to learn the things that they need to learn while really honing their entrepreneurship and providing them internships and real life applications to what's happening in local communities and sort of really tangible ideas of what they could do with their career. And so this program has received funding from the Gates Foundation to replicate across the US. There's over 100 schools now across the US and around the world. President Obama has talked about this in his addresses, and it all started right here. And so these are examples of programs that are happening to address social determinants of health. Another important one is the medical legal partnership. And we have Janine here to talk a little bit about it so we can dig into it with a little bit more detail. That's also a very innovative, important program. So I'll turn it over.
Thank you very much for having me. Some of you are probably wondering why a lawyer is here today in the first place. But I want to make the case that legal needs are, in fact, health needs. So you're getting sort of a random tour of my slide presentation. But I don't think it takes very much convincing to know that a denial of SNAP benefits is going to cause food insecurity for the family. It doesn't take very much to make the case that a child living in an unhealthy house is going to cause health issues for the family living there. So the idea is that for me, an attorney, to be co-located with doctors in a healthcare setting so that we can collectively address those social determinants of health. Because basically, doctors are really good at that clinical setting, that prescription doing, but they're not good at yelling at landlords. So that's where I'm going to come in and do something a little bit more about that. Problem is in Rhode Island, and it's true across the nation, is that the access to attorneys is quite low. Could I have one more bit of assistance? So I am a digital immigrant, okay, and there may be digital natives here, so if you could just bear with me one moment. It's not clicking over. No. It's a really good slide. I really want you guys to see it. So, yeah. There we go. All right, so you can see, I want to show this slide because it has a very big impact. It may feel like in Rhode Island, you can take 5 steps and you're tripping over an attorney. But the truth is that when it comes to legal aid attorneys, that it's basically one attorney for almost 6,000 people. All right, so that means that access to legal services is extremely limited. And while in Rhode Island we haven't done a recent civil legal needs assessment, we can extrapolate from a recent study in Massachusetts that's found that for every low-income family, they have 2.5 unmet legal needs. And what those legal needs are is help with landlords who are failing in their maintenance duties. It's help with denials of benefits and so forth. This story, this slide to me is very important, especially in light of a recent story that I read about a family who had a set of twins. These twins were born in the late 80s, premature, and by the age of 22 months, the boy twin had a lead level of 37, okay? So, but even though the family was able to sue their landlord successfully and received an undisclosed settlement, what happened was that child was on that track of special education, ADHD diagnoses. He was arrested multiple times, and eventually he died in police custody. And some of you may know him. That was Freddie Gray we're talking about. So he's a very interesting example about how if maybe the family had had a little bit of a different kind of intervention, not a secondary intervention where you're doing a tort liability personal injury claim case, but one suing the landlord to act preventatively to make sure the house was up to code in the first place, this would have been at least one point of intervention where maybe Freddie Gray's health outcome might have been a little different. Okay, I'll get off my soapbox a little bit about that, but I do want to tell you that every single day I receive referrals from the primary pediatric clinic at Hasbro Hospital. I serve approximately 7,000 families. I also take on referrals from a number of other departments in the hospital. This the PowerPoint isn't working right now, so I'm just going to wing it, which attorneys are really, really good at. Okay. So let me give you an example of what a referral might look like. So a doctor has identified a child with asthma. That doctor will send the child, will give out prescription, maybe it's albuterol. Maybe the parent has an opportunity to talk to a social worker, and the social worker is recognizing that as much as she can provide support on how to do maybe cleaning up the environment differently, trying to reduce those environmental triggers on her own path, that really what's at fault is that the landlord isn't making the maintenance repairs as required. So that's when perhaps I'm being connected and I can go through the process of trying to hold the landlord accountable and make sure that that house is safe not only for that family, but for every other family who will move into that home. It's not, yep.
I'll show you exactly. I'm just going to show you how to do this. You can do it yourself.
Okay, thank you.
These
All right.
arrows right
Those
here
ones
at the
work.
bottom.
Okay.
Yeah, sorry.
All right, that's all right. But it's not just housing. This is sort of the model that medical legal partnerships use, this I-HELP model. So income supports, housing and utilities. I do some work around special education, helping families to understand their IEP process, what their rights are from the school. I do a little bit on immigration, helping families with status, and also dealing with personal and family stability, which can look like anything from helping a domestic violence survivor access a restraining order to working with guardianship so that minors who are aging out of that juvenile system will have continuity of care because their parent will have guardianship and legal authority to make medical decisions. One thing that Dr. Sanchez said earlier today that I thought was interesting was about breaking down these silos, and this is sort of where I see our silos, is that we have doctors in their one area with the patient. We've got public health that is doing disease and population level assessments of laws, and then there's where I am trying to also be part of that system. The medical legal partnership model actually was first developed in Boston in the late 90s. It has now been spread across the US, and it's a model that honestly should be, I wish our numbers were even higher, because I am in the hospital. The patient family doesn't have to go out, take a bus with their 4 children to another location. I'm right there. I can see them in the exam room. I can see them in my office. The hospitals are often very familiar places for families, and the same thing could be said about health clinics. So I wish our number is higher, but I think the case for how legal interventions can affect social determinants, health outcomes positively, that is the case that I think is being more and more. And I love having data from scientists to sort of back up that what social determinants and how they affect health can include legal interventions as a way to resolve some of those problems that are being highlighted by the data. I also will help with training. So a lot of doctors, especially residents, are learning a lot about medicine and a little afraid to ask about what's actually happening in the house. So part of what I do is help doctors ask those questions so that if they hear an answer that is outside of their training, that they are able to refer to my program. Okay, and some of the MLP outcomes that we've seen across the nation, it really varies. It can be from that single person who has had their house better improved. There's been particular work in reducing crises that are going to affect the sickle cell patients. And I'm going to give you the whole list so that everybody can read this at once. And one of the other arguments is that if we are saving on patient health care, that any investment into a medical legal partnership is going to have a higher return on that investment, not only for their health care cost savings, but also on the improved health care. All right, so this was a very quick overview of the medical legal partnership, and I just wanted to sort of give the opportunity to see at Rhode Island that we have the only medical legal partnership, and I encourage all of you to consider expanding into your own systems, and I'll return it back to Dr. Luke so that he can continue this presentation. Thanks.
So again, as it was presented earlier, I won't go into too much detail about what the social and environmental determinants of health is. Of course, it's the conditions in which we live and work, such as quality housing, as you heard earlier today, housing in regards to lead, in regards to pest control. Those are all the things that impact our health. As far as quality of food, access to food stores, again, transportation has a direct impact. If you can't get to a store that has the nutritious food, then it will impact your health outcome. Dr. Sanchez said it really lovely in terms of the educational aspect. So education does play a huge role in whether or not good health outcomes can be achieved. So I would say, to Dr. Sanchez, thank you for laying the groundwork, because absolutely education in itself does directly impact health outcomes. I'm not going to spend too much time on this trajectory because, again, Dr. Loucks did go through this. But what I will say that I think is important to outline here is that zip codes do have an important aspect on life expectancy, particular with health and wealth, in terms of being able to have access to pharmacy, being able to have access to the best medical services depending on where you live. So I will not go so much into this slide because I think Dr. Loucks did a wonderful job talking about the epidemiological aspect of it. I really like that stuff, so thank you. So here's the part that I'm excited about. So the Rhode Island Commission on Health Advocacy and Equity was formed, I want to say, a little over 2 years ago. We just really have gotten into the mix of our work. But I will say one of the efforts that came out of this in terms of reducing health disparities was this commission. I want to give a plug to our General Assembly because they're the ones who foreseen this particular topic of interest and really formed the commission. So I want to give a plug to them to say that they really see how important this work is for Rhode Island. Our role specifically, and this is just some of our key roles, but absolutely it's much bigger than this, to advise the Department of Health on disparities in health equity, including the policies and programs, to encourage intersectoral collaboration across state agencies and to create health equity. And this is done by really collaborating with departments of transportation, Department of Environmental Management. All these departments have a direct impact on the health of Rhode Island, so it's very important that they're at the table with the commission on determining what our next action steps should be. And also preparing the biannual report on health disparities in Rhode Island, which we just completed our first 2015 report, and I believe it may be available here, and it was absolutely amazing what we found to be some of the high priorities and some of the action steps that we feel that the state should take. So, oops. Oh, so I'm going too fast here. Oops, I can do it without the slides. So one of the elements of the reports was to look at different areas, and we selected areas that we found to be of importance. Not that this list that's up here is not. There's some things that, of course, others may think that is equally important. So maternal child health. So improving birth outcomes in Rhode Island is absolutely one of our important aspects for women's health in the state. Asthma is another one, and that's directly related to housing, schools, as well as obesity. Obesity, of course, is related to nutrition, safe housing, safe neighborhoods. Not being able to get out in your neighborhood to walk is also very important. Diabetes and heart disease, of course, very much related. Diabetes, of course, is more prevalent, or the poor outcomes for African Americans is more prevalent, in that community. And oral health, recognizing that oral health is directly related to physical health. So recognizing that we have to talk more about how oral health is linked, I think is also important. And I'll get there. So again, with the maternal child health, I want to say also a plug for the Rhode Island Health Department. They have plenty of programs aimed at reducing health disparities for maternal child health. We have a task force on preconception care, which I think is very important to look at this in specific educational aspects. Disparities involved in access to care. A lot of the nuances that we are finding is that there's no preventative care. So the preconception education is a direct link to preventative. How can we prevent the next pregnancy from having a poor birth outcome? Well, looking at it preconceptually would be that aspect. I'm not good here. Asthma, again, Dr. Loucks talked about how asthma, the environment, the pollution, the schools, some of the schools in Rhode Island do have molds, leaky roofs, poor air quality. A study was just done by a student in this year's 2015 science fair, where she did some studies in her school and found there to be a high quality of mold, and the air quality was also very poor. So we do know that this is an area that we need to pay close attention to. Housing, again, the pests, the education, the unsafe housing. I'm just going to go to the very end of my presentation because I think this is the most important slide that I'd like for everyone to glean. The Commission recommends that we establish a state grant process that facilitates programming across the state agencies that influences the social determinants of health. For example, the education, the transportation, because again, it's directly linked to if you have access to services, how you get there. Transportation is important. Employment and training, so social class. If, the poorest individuals, if they don't have opportunity for wealth or to even get to the next stage of being able to have opportunities for income, then we'll never get there. And lastly, in conclusion, to achieve a healthier Rhode Island, we need to focus on the social and physical environments. I know I'm preaching to the choir, but this means working to enhance the economic stability, again, about wealth and opportunity, access to health care, and neighborhood quality for all Rhode Islanders. And again, I encourage everyone to get a copy of that report because I know I didn't do the report justice in this presentation. I just thank you all, and I know that we're all on the same page of knowing and recognizing the social determinants of health. I thank you.